SCLERAL IOL Fixation Flange Technique by Dr. Dennis Kong, Eye Specialist Center, Kuching. No relevant financial disclosure. This is a 43-year-old myope who had uneventful bilateral phaco and implant in 2013. He denied any trauma. Right eye noted to have increasing vitreous in the AC and IOL subluxation from around March 2019. Similarly, the left eye also noted to have increasing vitreous in the AC and IOL subluxation from May 2022. Right eye with vitreous in the AC. This is the left eye with vitreous in the AC as well. The right eye with vitreous in the AC and IOL donisis. 180 degrees marking at the optic haptic junction, and then 2 millimeters from the limbus, and then on both sides. And then the second marking at 3 millimeters from the limbus. Injection of OVD into the AC. 2 paracentesis were done at the adjacent to both sides of the axis marking. The 27-gauge needle was inserted at 3 mm from the limbus and posterior to the IOL and passed through the eyelet of the Invista lens at the optic haptic junction with the aid of a second instrument. 6/0 polypropylene suture was then cannulated through the needle, and then the suture externalized by withdrawing the needle. The suture was then cut and cauterized till a terminal bulb has formed. The 27-gauge needle was then inserted at 2 mm from the limbus and anterior to the IOL. The other end of the suture was now cannulated through the needle, and then the needle withdraw, and thereby forming a loop around the IOL. The suture was then cut and the end cauterized till a terminal bulb has formed to secure the suture temporarily. Similarly, the 27-gauge needle is passed 3 mm from the limbus from the opposite side, posterior to the IOL, and with the aid of a second instrument, the needle is passed through the eyelet of the IOL into the AC. Another piece of 6/0 polypropylene is then cannulated through the needle, which is then withdrawn, and therefore the suture externalized. The suture is then cut and cauterized till a terminal bulb has formed. 27-gauge needle is then inserted 2 mm from the limbus and passed anterior to the IOL. The other end of the suture is now cannulated through the needle, and then the needle withdraw and the suture externalized, and thereby forming a loop around the IOL as shown in the video. The centration of the IOL is then checked properly, and then the suture cut. The end of the suture is again cauterized till a terminal bulb has formed. More cautery is then done to shorten the suture, and then check that the terminal bulbs are flush with the sclera. The other side is then checked, and the centration of the lens and suture is shortened and then cut and cauterized. A bit more cautery to shorten the suture and also enlarge the terminal bulb. Triamcinolone is injected into the AC to highlight the vitreous. Interior vitrectomy is done via 2 side ports. More interior vitrectomy is done in the AC to make sure that there are no more vitreous strands left. Post-operation 1 month, showing a well-centered lens and unaided visual acuity of 6/7.5. In conclusion, the video demonstrated a minimally invasive technique to fixate a subluxated IOL to the sclera using polypropylene 6O. Basically, there are only 2 side ports and a main incision, and no conjunctival peritomy. The other significant advantage is that the 6O is much more durable compared to the 10O or 9O polypropylene that were commonly used. Thank you kindly for your attention.